Welcome to the CJD Foundation virtual conference and tonight's keynote address. We thank our partners, the National Prion Disease Pathology Surveillance Center and the Centers for Disease Control and Prevention, and our sponsors, Ionis Pharmaceuticals and Charles River Labs. Tonight's address will be delivered by Dr. Brian Appleby. We're grateful to Dr. Appleby for his work not only as director of the Prion Center and as a clinician, but as medical director of the CJD Foundation. We look forward to his address. But first, Dr. Appleby will be introduced by Dr. Pierluigi Gambetti. As many of you will recall, Dr. Gambetti established the National Prion Disease Pathology Surveillance Center and also served as the medical director of the CJD Foundation for many years. His important research, discoveries, and passion for making a difference in the prion field are deeply appreciated. He was an important part of the evolution of the foundation as well as our past medical director. We well remember his compassionate and patient support of families affected by prion disease. His lifelong devotion to the prion disease field and to the families continues to inspire us. In recognition of this, the Board of Directors of the CJD Foundation has chosen to honor Dr. Gambetti by naming the keynote address in his honor, starting with this year. And so tonight, Dr. Appleby will be delivering the Dr. Pierluigi Gambetti keynote address. To introduce Dr. Appleby, here is Dr. Pierluigi Gambetti.
I'm very grateful to the CJD Foundation, especially to the President, Debbie Yobbs, and the Board of Directors, for the honor of naming after me the keynote address and of introducing the keynote speaker at the 2021 virtual conference. The participation to this conference gives me the opportunity, although virtual, to meet and once again salute you, the family of prion disease victims. The many family meetings I attended in Washington, D.C. were invariably moving and enlightening to me. The pain and the profound sorrow of losing a loved one to this horrible disease were palpable, but so were the courage and the generosity of the families who came each year wanting to help in any way possible to defeat this disease. The 3 days we spent together at this meeting gave me a better sense of my work and sharpened its purpose. Thus, at the end of my career, I'm very grateful for the opportunity to thank you again today. It is now my pleasure to introduce the keynote speaker, Dr. Brian Appleby. And here I'll do my best to summarize his impressive 23-page CV. Dr. Appleby graduated from Georgetown University Medical School and trained at Johns Hopkins University. Fortunately for us, in 2013, Brian joined Case Western Reserve University, where he is currently professor of neurology, psychiatry, and pathology. Brian is a recipient of many honors and awards, which include the Francis L. Clark Jr. Award, the Champion for CJD Family Award, the CJD Foundation Award, and this year, the Edward L. Westbrook Excellence in Teaching Award. He's also the author of over 100 publications. More importantly to us, since 2017, Brian has been director of the National Prion Disease Pathology Surveillance Center at Case Western Reserve University. Being myself the founder of the center, I could not ask for a better successor. Last but not least, Brian is more than a colleague. He's a trusted friend who provides support and advice when needed, as I experienced myself even recently. Today, Dr. Brian Appleby will present to us a historical appraisal of the field of prion diseases, what we have learned, and why we should be optimistic. Brian?
So thank you very much for inviting me to give this talk. I should say at the beginning that the title of the talk, Historical Appraisal of the Field of Prion Diseases, what we've learned and why we should be optimistic. You should know that I'm not inherently an optimistic person. So this is a little out of character for me, and I think it speaks to the true nature of what I'm discussing. I think also it's important to know that I wouldn't have such a talk for many of the other illnesses that I see. So some of what we're going to be talking about today is unique to prion disease, and that in itself is exciting. But of course, this talk is now named after Dr. Pierluigi Gambetti, which is quite fitting because much of what I'll talk about today features Dr. Gambetti. And for many of you who aren't aware, Dr. Gambetti has done a lot for the field of prion disease, especially within the United States. So just a list of some of his accomplishments. As we'll see later, he basically came up with the subtyping with his colleagues for the molecular subtyping of sporadic CJD. He also co-discovered 2 novel prion diseases, fatal familial insomnia, a genetic prion disease, as well as a different sporadic prion disease called variable protease-sensitive prionopathy. And of course, we would not have the National Prion Disease Pathology Surveillance Center had Dr. Gambetti not started back in 1997 when he was working with the CDC to institute its existence. So we have a lot to be thankful for Dr. Gambetti, and as you'll see, he has a big reason for why we should be optimistic about the future of prion disease. So as I said in prior talks, this is kind of an intermediate level discussion about prion disease, and we're well aware that families come to us with a variety of backgrounds, sometimes no background at all, or they want a lot more detailed conversation. So I point you to 2 sites. Again, if you're new to the field and you need basic information written for lay people and for families in particular, I'd highly recommend the CJD Foundation website, where there are a variety of text and also recorded conversations on specific topics. If you want more in-depth clinical or science-related information, you can go to the Prion surveillance site at cjdsurveillance.org. There's also some more information there. So for today's talk, 3 primary themes. First, I'll provide a very quick overview of the history of prion disease. I'll present some important advances to human prion disease that we've seen within the last 10 plus years. And then finally, I'll lay out why I think one should feel optimistic about the field of human prion disease in this day and age. So of course, Creutzfeldt-Jakob disease is named for Creutzfeldt and Jakob, who first described the illness. Actually, it was Creutzfeldt who had a case report that later Jakob included in a case series of his patients that came up with the syndrome of Creutzfeldt-Jakob disease. And Jakob's 1921 paper, he basically provided a clinical description of the illness by saying that this is a disease of middle and late life, which begins with disturbances of the motor apparatus and of sensation. The patient's gait is strikingly uncoordinated, striking mental changes appear in the form of apathy, negativism, delirious, and hallucinatory confusional states. The course of the disease is subacutely progressive of several weeks to a year. Now, unfortunately, to many of us, that seems well too familiar, but you have to remember in 1921, that's all clinicians had to go by, is just a clinical description. And as you also are well aware, going through what your family went through, there are many other diseases that actually look like his description. And of course, probably not surprising, many of the cases that were initially described as Creutzfeldt-Jakob disease in this case series actually wound up not being what we would now call prion disease. So at the very beginning, all we had was this clinical description. Fast forward to 1957, where we really started learning a lot more about prion disease with the introduction of Kuru, which was a prion disease of the Foray linguistic tribe in Papua New Guinea. Basically, they had a acute onset ataxia or drunken walking, basically, and some late stage dementia that was very rapid, and attracted researchers from around the globe to try to discover what was going on. Initially, it seemed that there was a pattern that women and young children were primarily affected. So many thought that it was initially a genetic disease. And then when the anthropologists got involved, and through a variety of different experiments that I'll talk about shortly, they learned that actually this was a transmitted disease through one of their mortuary practices of cannibalism, where the loved ones would consume the deceased out of respect for them. And that's how the disease was transmitted. But of course, CJD, prion disease, this is how we first learned that it was transmissible in the context of Kuru. After that manuscript was published, a veterinarian by the name of William Hadlow wrote a letter to the same journal describing similarities between a disease in sheep and goat called Scrapey, which was named because these animals would have this intractable itchiness that they would scrape up against the fences, basically. And it was a neurodegenerative disease, so they passed eventually, and it seemed to be transmissible. And what he noticed was that the pathology that was demonstrated in that initial Kuru paper was very similar to what he noted in Scrapey. A couple of years later, Chandler also did a very pivotal study where he actually took brains of Scrapey infected animals and inoculated it into the brains of mice, and was actually able to transmit a Scrapey-like illness in those mice that had similar clinical symptoms, but also the neuropathology was also similar underneath the microscope. So it was demonstrated that Scrapey was a transmissible degenerative illness. So because of the similarities between Scrapey and Kuru and this new finding that Scrapey was a transmissible neurodegenerative illness, Gadashek and colleagues then actually did a very similar experiment where they took brains of Kuru-affected patients and transmitted it to the brains of chimpanzees. And lo and behold, those chimpanzees also developed a Gurulike syndrome with pathology that was very similar to what you see in Kuru, demonstrating that this also was a transmissible neurodegenerative disease. There had been also some talk that what we had discussed as Creutzfeldt-Jakob disease also had very similar pathology to what you see with Kuru and Scrapey. So Gibbs, who was in Gadashek's lab at the time, and colleagues did a very similar experiment where they took brains from patients affected with CJD, again, inoculated it into the brains of chimpanzees, and they also were able to demonstrate a transmission of a CJD-like syndrome, both clinically and neuropathologically, in these chimpanzees that had been inoculated as such, demonstrating that CJD was a transmissible neurodegenerative illness. Fast forward about 20 years, a lot of research had been done at that time, but a lot of that research was very well reviewed in a paper published by Stanley Prusner in 1982, where he very eloquently reviewed all the research that had been done that basically looked at how these illnesses were transmitted. And there was a very unusual finding in that most things that are transmitted and replicate in nature have at its basis, nucleic acid, right? So these are the building blocks of life. And you see them in viruses, you see them in bacteria. But anytime any of the researchers did anything that would eliminate nucleic acids, and you would expect that with the nucleic acids gone, transmission would also be eliminated. That wasn't the case with these illnesses, Scrapey, CJD, Kuru. They still transmitted, even though if you did things to eliminate nucleic acid, they still transmitted. So he came up with the thesis that basically these illnesses were caused by a transmissible protein. And he termed this prion, which basically stood for this transmissible protein that was necessary and sufficient actually to cause the disease. And what was interesting later on is we later discovered that actually it was one of our own proteins that we all make. We all make normal prion proteins that serve a role in our body, but when it assumes a different 3D conformation, it becomes pathological and causes disease. So of course, Stanley Prusiner won a Nobel Prize for this. After that, people were able to discover and isolate these abnormal prions and study them in more detail. We learned of things like genetic prion disease, where there's a genetic mutation in the gene that makes the normal prion protein in humans. So I'm going to fast forward to 2008, and I use 2008 because that's when I actually graduated fellowship. So it wasn't too long ago. And I'm going to tell you how I diagnosed a case of CJD when I graduated fellowship. So the criteria that we had at that time was basically this: clinical syndrome matched with 2 possible diagnostic tests. So that clinical syndrome was basically a progressive dementia or cognitive issues with at least 2 of the following 4 clinical features. The patient could have myoclonus, which is a twitchy movement. They could have visual symptoms or cerebellar disturbance, which is a uncoordinated walking or movement. They could have focal weakness, or they could have Parkinson's-like symptoms. And then at the very end of the disease, they develop a syndrome called akinetic mutism, which is lack of volitional speech and movement. So you had to recognize the clinical syndrome, very similar to what was described initially in 1921, Creutzfeldt and Jacob's cases. And then we had 2 diagnostic tests that we could use at our disposal. We could use an electroencephalogram or EEG, which looks at brain waves of patients. And there is a very characteristic pattern that we see with CJD called periodic sharp wave complexes. However, it doesn't occur in every case. And when it does occur, it usually occurs in only a specific part of the illness. So not too helpful, but again, that's what we had. And then also we had a protein in spinal fluid that we could look for that actually is a normal protein, but because of the neuronal death, the brain death that happens with CJD, it's released in vast quantities and much higher levels than what we see with normal individuals or other brain illnesses. And that protein is called 1433. So those are the 2 diagnostic tests that we had at our disposal in 2008. And of course, the most important part of diagnosing prion disease, and this stands today, is that there is no suggestion of any other alternative diagnosis. Now, this is 2008, but the criteria that I was using was actually from 20 years prior to that. So in 2008, we were using criteria that was 20 years old, and we were able to make diagnoses in a relatively reliable fashion, but it was difficult. And as you can imagine, usually it was done fairly late in the disease course. So that's a very quick and brief overview of the history of prion disease. I now want to take you through what I think are the most important advances in human prion disease since 2008 that I've seen. And I do have to say some caveats. I came up with a top 3 list because when you go on the internet, that's what people tend to do. So I wanted to keep it simple. But these are my personal opinions. And of course, that's going to include my personal biases. I am a clinician first and foremost. I see patients, and that for me is going to be the most important piece of advances in the field. Their choice obviously is going to be guided by the tone of this presentation. So there has to be optimism to the findings that I'm going to review. And I have to also say that there are a lot of equally important advances that I'm not reviewing. And it would be very interesting to see a basic science researcher give a very similar talk to see what they would come up with. But of course, we have to limit the discussion, and this is my top 3 list. In my opinion, the most important thing that's happened since 2008, and a little bit before that, is the expansion of the clinical phenotype of prion disease. Now, in science, the word phenotype basically means appearance. And in the clinical world, it means what the patient looks like, but it also can refer to what a patient's brain looks like underneath the microscope. And this is where Dr. Gambetti played a huge role. So, as you know, sporadic Creutzfeldt-Jakob disease is the most common cause of prion disease. It makes up about 85% of all cases. But as many of you are aware, there are several different subtypes of sporadic CJD that look different clinically, neuropathologically. Sometimes the diagnostic tests will be different depending on the subtype. And basically, the subtype is denoted by a polymorphism or a certain code at the position 129 of the prion protein gene that we all have. We all have normal variants. You can either be MM, MV, or VV. And then we combine that with the prion protein type, which is basically demarcated by size on what we call a Western blot. And these are called, at least in Dr. Gambetti's classification system, type 1 or type 2. So for sporadic CJD, we combine that codon 129 polymorphism with the prion protein type, and we come up with a subtype that sounds like MM1, MM2, VV1, MV2, and so forth. Really has done a lot for the field and has really helped us learn a lot about prion disease in general. Now, of course, genetic prion diseases can look quite different. There are 3 genetic prion diseases, actually 4 now, but one of them is relatively rare, so I'm not going to talk about it. The most common is genetic CJD. That's pretty simple because it's named after CJD because it looks like CJD. So that's fairly straightforward. However, there are 2 other named genetic prion diseases called fatal familial insomnia and Gershman-Straussler-Schenker syndrome that I would argue doesn't even really look like what we had classically termed as a prion disease or CJD. So part of the expansion of the clinical phenotype is recognizing these very important different looking genetic prion diseases. And of course, Dr. Gambetti was instrumental in describing fatal familial insomnia. But there are other sporadic prion diseases, and probably the next most common sporadic prion disease outside of sporadic CJD is something called variable protease sensitive prionopathy, which again does not really resemble the CJD phenotype. And this is also something that Dr. Gambetti did with colleagues shortly before he retired. And of course, phenotype is very important for finding new prion diseases, as I described above, but very important transmissible prion diseases. So variant CJD is prion disease due to eating meat contaminated with mad cow disease. And one of the ways that variant CJD was discovered is that Dr. Will and Ironside, through their surveillance system, basically discovered young cases that looked different clinically and neuropathologically. And they were able to demonstrate that this was a novel prion disease that was very important because it demonstrated that the population was at risk and that something needed to be done for surveillance, but also regarding exposing people to mad cow disease. So why is this phenotypic description so important? Well, you can only diagnose what you clinically suspect, right? So when you go to the emergency room with chest pain, one of the things the doctor is going to do is ask you specific questions about the chest pain. And they're trying to determine whether or not that chest pain is due to a heart attack, a pulled muscle, pneumonia, reflux. That helps guide their examination and also their diagnostic test process. The same is true for prion disease. So there has to be a recognition that it could be prion disease for that diagnostic pathway to be continued. As I said before, it also allows for the capture of genetic prion diseases that would have been missed otherwise if we only assumed that all genetic prion diseases looked like CJD. It also allows for the capture of zoonotic prion diseases, which are basically transmissible prion diseases from animals. In this case, it's variant CJD. Of course, this is going to also probably be very important to help discover whether or not chronic wasting disease, a prion disease of deer and elk, is transmissible to humans or not. And because of that, it's a crucial piece of finding new prion diseases. And I think it's going to be very important for clinical trials because, again, you have to be able to recognize and diagnose someone with a prion disease in order for them to be enrolled in a clinical trial. But there are very important differences in phenotypes that are also going to influence how a clinical trial is conducted and interpreted. So my top number 2 advancement since 2008 is the brain MRI. So many researchers prior to that had talked about that there were unique findings in brain MRI of CJD patients, but really this was not completely elucidated until 2009 when a bunch of European colleagues came together and discussed criteria for a brain MRI. And in my opinion, I think this is extremely important for a variety of reasons. Number one is brain MRI is a very easy and non-invasive diagnostic test that can basically be done on everyone unless they have a incompatible pacemaker or they have too much movement. And anyone who has a rapidly progressive neurodegenerative illness is going to get an MRI anyway to rule out other treatable illnesses. And fortunately, the brain MRI findings that we see in most cases of prion disease are relatively early finding. And in fact, it's so early that sometimes it may be the initial thing that raises the suspicion of prion disease. So an example of this is someone who has some memory problems that goes to a memory clinic or their primary care doctor. Their only symptom is memory problems. That physician orders a brain MRI and it shows findings suggestive of prion disease. And that may actually start the suspicion that that patient has prion disease. And then that diagnostic pathway is undertaken. Number 3 is a test called real-time quaking-induced conversion, or RT-QuIC. This is the first anti-mortem disease-specific test, meaning that it can be done in living patients that's disease-associated because it detects the abnormal prion protein itself. Of course, you can do this with brain biopsy, but we don't encourage it because we do have much better diagnostic tests. You can actually get a false negative brain biopsy. And of course, if you don't have to subject a patient to that, we prefer that you not. It has excellent specificity. So in the medical terminology, specificity is how good your test is detecting at the disease that you're specifically trying to detect. And because of that, and because it's disease specific, meaning you wouldn't expect to find abnormal prions in other diseases, what we found is that it definitely increases the clinical confidence in that the clinician that receives the positive RT-QuIC result is much more likely to give the patient and family the diagnosis of prion disease, even if some other test may be pending. They at least let the families know that this is highly suspected. And I think that's very important. This and other assays may actually be helpful in differentiating different types of strains or phenotypes or types of prion disease, which I think is very important for surveillance and likely also for treatment trials. It can also be used in the basic science world for screening for potential treatments. If you have a drug that inhibits RT-QuIC conversion, that could be suggestive that that is a treatment that should be explored further. And very excitingly, this test is also now being investigated in other protein misfolding disorders. So these are mostly neurodegenerative disorders that are also caused by abnormal proteins that we all make, such as Parkinson's disease and Alzheimer's disease and frontotemporal dementia. So because of that, it's getting a lot more prime time coverage, and that's good for prion disease as well. And perhaps most importantly, this test is so powerful and so specific that it has drastically affected our diagnostic criteria, where now you only need a non-specific neuropsychiatric disorder plus a positive RT-QuIC result. And that's quite different from the criteria that I had been using in 2008, because what this means is that they don't have to have that full clinical syndrome of CJD for a diagnosis. It's more reliant on what we call a biomarker or a diagnostic test that is specific for the disease. And that's very different. And also, this is somewhat different from what we see with other neurodegenerative diseases, although we are seeing some progress in them as well. So in my opinion, those are the most important advances to human prion disease since about 2008. So now I'm going to change gears and I'm going to explain why I think people should feel optimistic about the field of human prion disease. Just a brief review, a summary of what we've gone over, and maybe some additional things. Again, CJD was first described in 1921, 100 years ago. CJD was first transmitted to chimpanzees. The term prion was coined in 1982. Shortly thereafter, Dr. Gambetti and colleagues described fatal familial insomnia. Variant CJD 1433 had been described. Tau was used shortly thereafter for diagnostic testing. Dr. Gambetti in 1999 with his colleagues came out with the sporadic CJD subtyping. A very important precursor to RT-QuIC called protein misfolding cyclic amplification, which was basically developed by Dr. Claudio Soto, came on the scene. And again, without PMCA, I'm not sure we would have RT-QuIC, so it's very important. Dr. Gambetti and colleagues then described variable proteosensitive prionopathy. The MRI criteria came out in 2009. And then in the early 2010s, RT-QuIC started being described, and then at least in the US was used routinely since 2015 for diagnosis. And then very excitingly, in the last 2 or 3 years, we've actually had pharmaceutical companies interested in treating prion disease. And I would have never had thought that a pharmaceutical company would have been interested in prion disease. And now we have a couple that are actually interested and publicly interested in pursuing prion disease treatments. Very exciting. Now, again, I didn't review every groundbreaking achievement in prion disease, but you do see a pattern here that as time goes on, we get more and more substantial and more frequent achievements in prion disease. And this is reminiscent of what Ray Kurzweil, who's a very interesting gentleman, often referred to as a futurist, terms the law of accelerating returns. And basically what he did is he looked at something called Moore's law, which basically describes how many transistors you can put on a computer chip. And Moore found that basically that doubles every 2 years. And Kurzweil then took that paradigm and applied it to all kinds of different technologies. So in this graph, you see the technology basically applied to computing power for $1,000, but he also applied it to things like genetics, biomedical research, basically what have you. And what he found is that technology in general, instead of actually progressing linearly, it actually progresses exponentially in a logarithmic fashion. And you see that in this graph with computing power, but we also see it in prion disease. And living in the field of prion disease from 2008 to 2021, I certainly get the feeling that we are in this inflection point that is described by Kurzweil, basically describing this exponential growth of technology within the field of prion disease. So despite anything else I would say, we could say that any technology should be optimistic, because as technology progress goes on, it increases in an exponential fashion. But there are a variety of other things that I think are unique to prion disease that should make you feel optimistic. If you haven't guessed, we have much improved diagnostic biomarkers. We have sensitive, meaning that we can detect things fairly well, and specific, meaning that we can detect exactly what we want to detect. Biomarkers or diagnostic tests. One of them is usually present very early in the disease course in brain MRI. A very important finding that was described by Dr. Beasy and colleagues is that if you look at RT quick and combine it with brain MRI, you pretty much capture 100% of all sporadic CJD cases. That's very, very valuable. And I can't give you statistics, but I'm sure that was not the case in 2008. Now, there will always be an issue with early clinical suspicion of prion disease, because in order to go down the diagnostic pathway of prion disease, the clinician has to have a clinical suspicion. And I would argue that we don't want clinicians automatically assuming that people have prion disease when they demonstrate short-term memory problems when they come to clinic. It should be low on the differential, but there should be things that are much higher in the differential diagnosis, because those things are treatable and much more common. But again, I think that especially with brain MRI, this will help clinicians, even if it's not on their radar, to perhaps consider cases of prion disease in someone that might not look like prion disease clinically. We also have biomarkers for disease progression. Now, there are a variety of these, too many to go over, and I chose this paper because it looks at a variety of different predictors of progression that we use clinically, and I'm sure will be used in clinical trials. That includes age, gender, that codon 129 polymorphism, and then also tau level. And as you can see, you can use a grid that takes all these factors and gives you a score, and you can go back and actually predict disease duration. Now, this is very valuable for families who often want to know where their loved one is in the disease process, but it's also very important for things like clinical trials. And again, this is just an example, and we have many other things that we can glean information from for disease progression. And that's not something that we had before. And then finally, it's the genetic therapies for prion disease. This is what's really exciting and very valuable, and I think somewhat unique to prion disease as a whole. So again, we all make normal prion proteins. We have a gene that results in us producing prion proteins, and we need prion proteins to have prion disease. So number one, they're fuel to the fire. In other words, you have to have the normal prion protein in order for it to be converted into the disease-associated form. But we also know that the membrane-bound prion protein is actually important to cause toxicity caused by the abnormal prions. So if you don't have the production of normal prion proteins, that significantly interferes with the disease process. I have to have a caveat that we don't know exactly what eliminating prion proteins would do to a human, but there is some evidence that you can at least reduce normal prion protein production in humans without drastically significant adverse effects, although we still have a lot to learn about that. And very, I think, interesting in the last 10 years, and this is a change in pharmaceutical companies. It used to be that a pharmaceutical company would have a disease pathway where they would say, we're going to develop treatments for Alzheimer's disease. And increasingly what we're seeing is pharmaceutical companies based on a specific technology. So an example of this is a company like Ionis. All they do is make antisense oligonucleotides. So what do? They go and they look for diseases where their technology would have an effect. And we see this not just with companies like Ionis, but other genetic technology companies as well. Now that drastically favors the potential treatment for prion disease, because again, the prion protein is necessary for the disease. So if you can block the production or reduce the production of prion protein, it's very likely to have an effect on the disease. And interestingly, this approach could potentially work for all forms of prion disease because of the way prion disease works. Now, of course, it probably matters drastically when you give the treatment. So if you give the treatment after symptom onset, you kind of have a two-part problem. You have to stop the disease progression, but you also have to reverse damage. But if you're able to give a prophylactic treatment, something that prevents or delays the onset of the disease, presumably in someone who's at risk of the disease because they know that they carry the mutation, then your potential benefit for a genetic therapy is drastically increased. And I also have to say that the network that we have in the field of prion disease is very, very tight and works very well together. So these are just some of the things that has improved our network. And I'm sure I'm omitting organizations and people, and I apologize for that. CDC, yes, they care about surveillance, but they very much care about developing a treatment and better diagnostic for prion disease from the family side as well. The National Prion Disease Pathology Surveillance Center, of course, is very interested in surveillance, but we really do want to help with diagnosis, and we very much want to help with rolling out any potential treatment studies and to help with that process. CJD Foundation, obviously, this is top of their priority list, as well as other international patient advocacy and surveillance organizations. We now have a prion disease registry, largely created by Eric and Sonia. We also have very strong individual research groups, for example, UCSF in the US. And this may seem funny, but this is part of the exponential curve of progress, and that is modern means of communication and data sharing. So I inherited Dr. Gambetti's office, and I have to clean out some of his old files. And I have no idea how researchers did research back in the day. You would have to hand type out manuscripts, make copies, mail them to a journal, wait several months for the reviews to come back. It was just a very, very glacial space of progress. Now you can, quite quickly type up a manuscript on a computer, automate data, submit it electronically, know within a few weeks, hopefully, what the peer reviewers say. That drastically improves progress in research, but also such means of communication also helps with conveying diagnoses as well. And again, the pertinence of prion disease to other protein misfolding disorders, as we've seen with RT-QuIC, is only going to benefit prion disease, as well as those other disorders, but it really helps call attention to us and makes us pertinent. So in summary, we've come a very long way in the last century. We're much better at recognizing prion disease. We have much better diagnostic tools and ways to track and predict progression. Prion disease advances are building on one another, as we've seen in that exponential curve. The law of accelerating returns is definitely working in our favor. Prion disease is an ideal target for genetic treatments, and we're definitely seeing that in the last few years, and I'm sure there's more to come. And finally, prion disease has a community that's well established and definitely has a purpose, and you're part of that community. Thank you very much.
So thank you all for joining us. We greatly appreciate it. And thank you, Dr. Gambetti, as well, for joining us. It's good to see your face. A couple questions.
Likewise.
Great. We had a couple questions from people that were watching, and I'm going to send a couple questions your way, if that's okay.
Sure, I'll be glad, but you should answer. By the way, my really great compliments for your presentation. You did an incredible job in illustrating the progress, the pace, accelerating pace of this progress, and the basic touchstone or stepstones that were passed and during this period and accelerating recently. So thank you again, a beautiful presentation.
Well, I have to thank you for actually giving me stuff to say, because much of your discoveries were focused on that. And we definitely wouldn't be where we are today as a foundation or as a field without your work. So thank you.
Thank you. I'm sure many, many people have contributed to this, to the curves that you have shown, you included.
Yeah. So a couple questions from people that are watching. One of them is a two-part question from Rob. The first part of the question is, what percentage of people acquire prion disease from eating meat contaminated with mad cow disease?
Please.
So, so what we know is not that many, actually. So I think to date we have 232 cases worldwide. The majority of which occurred in European countries, England especially, where the mad cow crisis occurred. In the US, we had 4 cases of variant CJD, which is what we call people that develop CJD due to eating meat contaminated with mad cow disease. All 4 of those cases were believed to have acquired the disease overseas. So we don't think they acquired it in the US itself. Is there anything you want to add to that, Dr. Gambetti?
Well, it is also important that we don't have any more cases in the world, as far as I know, for the last at least 5 years, maybe more. No new cases of variant CJD. So the disease essentially has been stopped completely, as far as I know.
So one of the things we covered in an earlier video with Dr. Maddox is about incubation period. And I was wondering, could you talk a little bit about what we know about incubation periods in these human acquired prion diseases? And does that help explain why we're not seeing variant CJD anymore?
No, I think the main reason, well, first of all, yes, that doesn't mean the fact that we have not seen cases over the last 5 years or so. That doesn't mean that really the disease is necessarily has disappeared, because we may find new cases in the near future. I don't think so, but we cannot rule it out. I think really the disease is so rare, if not no more existent, simply because measures have been taken to avoid the contamination of the meat and meat products that was the cause of the disease. So simply eliminating the disease in cattle has solved the issue at this point. So I think that has been a great success based on the fact that scientists were able to locate the source of the disease, the animals affected, and then the measure to avoid future contaminations. I think this is really the result of great research that was done mostly in Great Britain, but also in a lot of other countries.
So the second part to that question, and I'm really interested to hear what you have to say about this from your perspective, is do you feel that prion disease in humans, do you feel that it's underdiagnosed?
Yes, I feel that this is the case, especially in the less well-known forms of prion disease, like the disease that you mentioned, variably protease sensitive prionopathy, or VPSPR. This is a disease that really is difficult to diagnose and recognize as a prion disease because it's relatively slow progressive. Has symptoms that are very different from those of CJD, and therefore can be easily confused with other conditions. It's also very difficult to diagnose by the instruments that are so effective CJD or prion disease, other prion diseases, as you mentioned very elegantly, that is MRI, RT-QuIC. These tests don't work very well in diagnosis VPSPR, this disease. So it's likely that this disease way is a prion disease, transmissible like the other prion diseases, but it's likely underdiagnosed because the diagnostic procedure that works so well for CJD don't work for VPSVR.
During my talk, I made a statement. I came up with my top 3 list of things that I thought were relatively the more important discoveries to the success of human prion disease. And I made a statement that I kind of wondered how a basic scientist would actually rate that list and what they would include. And after I was done recording, Debbie asked me, and I told her, I don't know. I'm not a basic scientist. So since we have a basic scientist on the call, could you tell me what would be on your list as the most influential progress that we've seen over the last 10 to 20 years that make you optimistic?
I really think is a better knowledge of these diseases. I think, well, first of all, but that happened before than 10, 20 years ago. The discovery of prion and of the prion mechanism, or the mechanism underlying the prion diseases, which turned out to be the same mechanism, that essentially the same basic mechanism that is active in other diseases. So the prion formation mechanism is shared by Alzheimer's, Parkinson, and other diseases based on disorganization and malformation of a prion. The prions are the proteins are different, but the mechanism of prion formation is fairly similar in all these neurodegenerative conditions. So that was the basic discovery. But yes, a better knowledge of the disease and the pathology, ultrastructure, and then the pathogenetic mechanism really is what has made the prion diseases well known and has made possible their diagnosis, because a very successful diagnostic procedures are an application or reproduction essentially of the basic mechanism of prion replication. That's how you can detect extremely small amount of prions which were before and which were undetectable before, because we learned, for example, with the RT-QuIC or PMCA, other procedure, to amplify these very few molecules, and therefore being able to see what was absolutely invisible before, and then make a diagnosis. One point I could make is that there has been, yes, as you, Brian, pointed out, tremendous progress in the diagnosis of these diseases with RT-QuIC, MRI, and I would add PET also. However, what is really important if we want to be successful in treating neurodegenerative diseases, and especially prion diseases, which have a very rapid course, is that we have the ability to diagnose these diseases very, very early. In this, for this characteristic, MRI and PET has been shown to be capable of diagnosing the disease even before the disease became clinically diagnosed or suspected. In other words, before the symptoms of the disease appear. If really this can be confirmed on a large scale of cases, that means that if we have, and when hopefully we'll have an effective treatment, we can really stop the disease cold before it even starts. And this, I think, is probably not certainly a goal that we have or we will be obtained in a very short term, but I wouldn't be surprised if in the future, not that far, that will become possible.
And you're specifically referring to people that carry a mutation that haven't become ill yet?
Well, that is almost already achievable, because in the genetic form of prion diseases, you can suspect more or less the period in which the disease will manifest itself clinically. That was how the PET study I was referring to was conducted. That is, if members of a family with FFI accepted very generously to have a PET scan once a year, or actually in some cases twice a year. And they carried these members carried the mutation. The non-carriers were used as control. And in a couple of cases, the PET examination was able to detect the disease, and no clinician, no EEG sleep study was able at that same time to detect the disease. So PET was by far the first diagnostic approach that recognized the disease. The symptoms start after that, 3, 4, 5 months after. So there was a quite long silent period. If we had the treatment and we started right after the positive PET, we would, and the treatment was effective, which we unfortunately don't have now, we could really stop the disease before it starts clinically.
So I wanted to switch gears a little bit to sporadic prion disease, specifically sporadic CJD. One question we hear a lot from family members, and I think it's a very good question, is what causes sporadic CJD? And I was wondering if you could give us your opinion on what you think might be causing sporadic CJD and possibly potential triggers.
Well, it is my opinion, really, because I don't think is based on any really firm data. My opinion is that these, not only prion disease, but also other diseases, start because of errors in formation and post-translational modifications of proteins, especially certain proteins. So in the case of the prion protein, that is probably a protein that has the tendency to be mishandled by brain cells. And practically, the system by which proteins are synthesized and then used is essentially a procedure that is like in when you make any product like a car, you put all the parts together, and then you test for quality to see whether there are no defects. And the mechanism of protein synthesis is very similar. But until when you're young, the system, the quality control system is very effective. And then it becomes, with age, less and less effective, so that misformed protein is allowed to pass and are not eliminated. Probably 1 in a million of this situation is that cause the prion protein to be malformed. And once that you have the first one, that the disease starts, because conversion of the other normal one will occur, and that will be the prion disease. Similar mechanism, probably unfortunately much more frequent, may occur with Alzheimer's and other age-related diseases. This is my opinion. To my opinion, makes sense, but very difficult to prove, really.
I agree with your opinion. That's the way I describe it. So I'm glad we're on the same page. I kind of equate it to cancer, right? Our body makes cancerous cells all the time, but generally is able to detect it and get rid of it. But the body's ability to do that goes down as it ages.
Well, yes, well, I don't claim that to have a very original explanation, but that probably happened also in a similar form in other diseases.
So what about young sporadic prion diseases? So there are some prion diseases like sporadic fatal insomnia that can occur in extremely young people, 20s, 30s, 40s. Do you think it's the same mechanism? What are your thoughts?
You know, that's the question we ask ourselves when we noticed that CJD subtype that we call VV1, that had, as I'm sure you have seen, these cases, that these had this an onset much earlier than the other non-genetic prion disease. And I thought many times, why could the disease could start so early? Certainly the hypothesis of an error in the quality, protein quality system that doesn't, quality control system wouldn't explain. A possible just explanation could be that the conformation of that particular protein, the VV1, prion protein is particular by which so that escapes also a well-functioning quality system, so quality control system, so that it's undetected even at younger age and goes on. That the fact that this disease is very, very rare, extremely rare, would go along with this explanation. But as I told you, is just a hypothesis.
I think that makes sense, though. So there was another question about the transmission of CJD. Can CJD and other prion diseases be transmitted through working with animals, or can they only be transmitted through the consumption of certain animals?
No, I think all depends on the type of proteins you are dealing with. Prion protein I'm talking about. We are talking about prion diseases. We know that virtually each disease has a different, each type of prion disease has a different protein, in the sense, different prion in the sense of conformation. So it all depends on the conformation of the protein. If you are exposed to a protein that's very similar to the human one, compatible with the human one, or the human one, like in an autopsy, as it unfortunately may happen, then you may, because it's not, even if you are exposed to regular small amount, very difficult. It's not so common to develop the disease. In other words, in my opinion, a small number of people exposed to abnormal infectious proteins actually develop the disease. But then, as I said, it depends all on the type of the protein. If the human protein, then is the one that is more infectious to human. But also animals could be infectious if they develop a protein that has affinity to the for the human prion protein, as is the case in the bovine protein, and so you develop variant CJD. So I don't think there are firm rules. It all depends on the type of protein you are exposed to. As you can see, the most common animal prion protein is by far the one of CWD, and yet there has been, I'm sure, a lot of exposure to CWD by hunters, but so far we have not seen a single proven case of prion disease acquired from elk and deer, from CWD affected elk and deer. So all is relative.
Good. So I think I'm going to take this next question. It's a question from Mark, and he had commented that his wife, who has prion disease, actually did not have an MRI that was suggestive of prion disease. And Mark, I think we can see that in two possible scenarios. One is it's not uncommon for MRIs to be misread in the community setting. And unfortunately, one of the findings of a MRI suggestive of prion disease can sometimes resemble what we call artifact, which is a abnormality of the scanner itself that's not considered disease causing, but just a factor of the scan. And sometimes it can be misdiagnosed as artifact. Sometimes it can also look like a stroke and is called a stroke. There are a few prion diseases where the MRI is not expected to be positive. So for example, fatal familial insomnia, the VPSPR, like Dr. Gambetti was talking about, for reasons we don't quite understand, most of the time those diseases do not have a suggestive MRI. And I had to laugh at another question, Dr. Gambetti, because someone asked, do you know any good people that can read MRIs?
Anybody who can read MRI?
Yeah, do you have any suggestions
the
of any
question?
doctors that can read a good MRI for prion disease?
I'm sure you can, and then we know. My nephew, Alberto Bizzi, but there are many really good experts, a lot of people with tremendous expertise in MRI in the United States. So I'm sure more likely that you know them. You read MRI. I'm sure you have a good eye to detect positive MRI for prion disease.
This is true. I was kind of hoping that you would mention Dr. Bizzi, because so many people, I think, that come through the foundation, they take advantage of the ability to have Dr. Bizzi read the MRIs. And it's extremely helpful to a lot of family members. And I think it's important to know that you actually helped start that process of the MRI consultation program many years ago. And it's really helped a lot of families. And I know they're appreciative.
Yeah, I personally think and I don't know whether you agree, it's not very difficult to become really a prion disease MRI expert. It's just the number of cases you see. It's such a rare disease that very few people have the chance to see hundreds of MRI from confirmed cases. So really develop an eye to detect the very early, small, sometimes misleading signs. So you are certainly one who have the chance to see a lot of these cases and therefore develop this eye. But Alberto Bizzi was exposed. He really was so much interested and had such a passion for knowing more and more about the MRI of this disease. And so probably has read, I don't know, 10,000 cases because he sees in Europe a lot of cases, and then the cases of the surveillance also. So it's very fortunate that the surveillance center can also have the advantages, the possibility of obtaining also the MRI from a large group of patients, because that is the basis of all Alberto Bizzi's work. His work is largely based on the cases of your surveillance center.
And I agree. I don't think it's difficult to read an MRI suggestive of prion disease once you've seen a couple. That's the problem. You know, it's not a common disease, and a lot of people haven't seen them. So
maybe more than a couple, but
yes. So I think we're nearing the end of our time. I just wanted to end with a couple more questions for you, Dr. Gambetti. So number one, do you feel optimistic about the field of prion diseases in terms of patient care and whatnot? And if so, why are you optimistic?
I am optimistic. The main reason as of why I'm optimistic is because I am optimistic in general. So my tendency is all for things that science can resolve all the problem. It's a matter of time. Unfortunately, for a patient, family of a patient, this time is very important. And unfortunately, I don't see a quick solution for treatment of prion and other neurodegenerative diseases, really ineffective treatment. As you probably you have read that recent there was a controversy with FDA concerning a drug that was used or was at FDA to try to be to have the permit to be used in treatment of patients with Alzheimer's disease. This drug is based on an antibody, as probably you have seen, and many people have seen. There was also recently in the paper. Really has been shown many years ago, in 2016, to be effective in decreasing the burden of amyloid beta protein, that is the prion, the equivalent of the prion in Alzheimer's disease. In humans, treatment with this antibody decreased really the amount of amyloid. It's like a CJD decreasing the amount of the prions in the brain. So it was really a great publicity, this discovery, and people thought maybe we have a treatment, effective treatment for Alzheimer's disease. And yet, when a lot of patients, so this was 2016, that discovery of this drug being effective in patients with Alzheimer's in diminishing the load of the abnormal protein causing the disease. But then when these patients treated apparently successfully with this drug were measured as for the rate of decrease of mental cognitive functions, it was found that there was not a really big difference with treated and untreated subjects had a diminution, strong diminution of this abnormal protein in the brain. So that indicates, in my opinion, this is a step forward. Even if it's negative, you learn a lot from this negative finding, but certainly indicate that difficulties ahead to find really an effective treatment are not indifferent, are quite big. But let's hope. We have to continue to hope and work for it.
So before we end, there are a couple questions that we didn't get to, but the answers actually are available for you on the CJD Foundation's website, cjdfoundation.org. There are a couple questions about COVID-19 as well as the vaccine. There was a earlier recorded talk with Dr. Ryan Maddox of the CDC where we did discuss that a little bit. So I would encourage you to check that talk out. And then there are a couple questions about the pharmaceutical companies interested in rolling out potential treatment studies for CJD. That also can be found on the CJD Foundation's website. So there's some recorded talks from those pharmaceutical companies themselves. So Dr. Gambetti, I'm going to leave you with the last word. Is there anything that you would like to say to the families and friends that have known you for such a long time?
Well, essentially, I just have to say again what I really said at the beginning. That is that I learned a lot during all this family meeting that I attended, and I admire the families for their generosity and dedication to the problem of solving this disease. Really, this determination taught me a lot. And from conversation with other researchers, I really, I was confirmed that I received confirmation that really also they had also the same reaction to this and sense of admiration, and therefore confirmation of their commitment to research to find the solution for these terrible diseases.
The families are a very big motivating factor, and of course they're the biggest part of the community that makes us whole. So we're very appreciative of all that they've gone through and also all that they do to further the field. So with that, thank you very much, Dr. Gambetti. It's really a pleasure to have you, and we really appreciate you joining us. Thank you all, and have a good night.
Thank you, and my compliment again for your presentation. Really outstanding.
Thank you.